Well, I do have a little bit of experience in training basic colonoscopy with the local assistants. But what I really want is to have that deconstruction that I think I have in colonoscopy to also, and not only deconstruction, but to be clear and succinct, but also understandable using understandable words, so that the message gets through in a environment which is possibly sometimes quite intense for the trainee. So mainly one, deconstruction, and two, getting the message across.
Well, I think the first thing I'd just like to say is that I think this is really tough. I thought particularly Lynn just now did a fantastic job, and great kudos to her for coming up first. And I think John's feedback was quite detailed, and I think it gave the impression that she hadn't done so well. But actually, I thought she was fantastic, and John was just really trying to milk the situation, really. So the first thing to say is that I think this is quite tough. And just sitting here watching the previous training, I think patience is really difficult, because, and I thought Lynn was amazingly patient with Melise, really. She didn't seem pushed at all. I think if you've got a trainer on your shoulder who's like really, trying to not showing that their patient is quite tough for the trainee. So I think I'd like to just say that I think this is quite difficult. I find training polypectomy difficult myself, because of the nature of the task, if you like, as well as the complexity in the language as well. So let me just say that. One of the things that John and I were discussing while the training was going on with Lynn was a plan. All right. So can I just ask you to think about, depending on what polyps were faced, it may not be that it's a polyp that requires a complex plan. You know what I mean? It could be a small polyp that we just inject and we take off. That doesn't really need a great plan. But I think it will make it easier for you as a trainer if you can discuss with the trainee exactly what you're going to do when, and agree beforehand. And then can you think about that to make your life a little bit easier? Okay.
Yeah.
I think the second thing that I'd just ask you to consider is the balance of intervention. All right. So I think there may be some moments where you've just got to give Tibor some space, and just think about it. It's when you're in that stressful situation, it's there's a tendency to talk more than not, if you like, and sometimes you just need to be quiet for a moment. Yeah. Notice also when Tibor says something that you disagree with, perhaps, if that happens, and think about why he might want to do something different, and try and get him to articulate that, and think yourself about it, articulate it. Right. And the fourth thing, I think, just on the language, is I think the tricky bit about the language is when you are giving instructions or trying to explain something, is, are you referring to the tip of the scope or of the cannula? All right. So just try and find some words that, make it clear that your instruction is referring to the tip or the cannula. If, you know what I mean? Because sometimes we want to push the cannula out further, but we might want to bring the tip closer as well, if you see what I mean. So try and, I think that's something that I find quite tough, is to be clear about what we're talking about. And in communication, I'd like you to be thinking about the communication with the assistant. If I'm just watching the last case and the cases yesterday, there wasn't really much communication with the assistant.
Then, well, that's an placement. You were talking about the V and the defect. it's I don't think it's a written rule to put the V not on polyp tissue. I don't think it's wrong. It's always wrong. Like for example, yeah, it's a bit in a valley. So I don't think it's always wrong to put it on lesion, but the defect does look nicer, and also you do get a little bit of more, or the risk of having islands in the center of the lesion is a bit higher when you put it on polyp. Sometimes you can't avoid it, but then again, place your snares sequentially in a way where you're confident. Actually, when you take your first polyp piece, think about the second one you're going to take. So V in defects, not necessarily into defect. You can also put it on normal tissue and put the tip of your snare into defect. So this you can actually also, you could have done this in mirrors. So like put the point in that defect and pull it back. But I think in this case, the shape of this defect lends it more to doing it this way.
So very briefly, because if you think about the real world, Sander, you don't have like a couple of hours to do a deep, you have like a few minutes before the next case, and you've got to be pretty snappy and sharp at the end of the day. So that's one trick that you have to learn, really. So just can you summarize with Thibault what he's taken away from this?
So I'm going to ask you, Thibault, what is your opinion that you've learned you will take away to your practice now?
So planning, dynamic injection, snare placement. I did learn some tricks there, so that were already important points, and I like the discussion we had on muscle entrapment or not.
Right. Sometimes there's a danger for two people to be talking, and there was none of that. There were a few periods of silence, which was good. So if you go back to the video, at certain times you were saying absolutely nothing, which is something I like to see. You don't need to chat all the time.